Hello, and welcome to today's educational talk on exploring novel approaches with PI3 kinase inhibitors in relapsed refractory follicular and marginal zone lymphoma. I'm Julie Vose from the University of Nebraska Medical Center, where I'm a professor and chief of the Division of Hematology Oncology and lymphoma expertise. In this segment, I will be giving an overview of PI3 kinase inhibitors in B-cell lymphomas. What are follicular and marginal zone lymphomas? These are indolent lymphomas for the most part. Sometimes they have some aggressive subtypes, but they're very common lymphomas. Certainly follicular lymphoma, very common. Typically, patients present with indolent history. They may have symptoms for months or even years. And when it becomes time to treat them, when they do have symptoms, they actually have a very long potential prognosis. And we treat these patients with multiple different treatments over years and years. So first-line therapy, if you look at all comers, the 5-year overall survival is about 75 to 80%. And there are patients that are alive 30 plus years after their original diagnosis. However, about 20% of patients do have very early progression within 2 years, so-called POD 24, and these patients are associated with poor outcomes. The overall survival at 5 years of these patients is only about 50%. So we do need effective therapies for many of these patients who have been multiply treated or that have early relapse and have a worse prognosis. There are lots of new exciting therapies for relapse refractory indolent lymphomas. Marginal zone lymphoma is another indolent type of lymphoma, certainly has different presentations than follicular usually. There are definitely effective first-line therapies, but there are fairly limited options that are currently available and FDA approved for relapsed disease. We'll talk about some of those today. The current NCCN guidelines are shown on the slide. So for follicular lymphoma for second line, their preferred regimens are listed there, bendamustine based with an anti-CD20 antibody or lenalidomide plus rituximab. There are certainly other regimens that are quoted there, and there's lots of different options. Certainly depends on what the patient got for the first-line therapy. For follicular lymphoma, relapsed refractory, third line or more, you can see the indications there. This is where many of the newer therapies come in. PI3 kinase inhibitors, there are 3 approved, copanlisib, duvelisib, and idelalisib. And for relapsed refractory, after having 3 prior therapies, umbralisib. Also, fairly recently, there's an EZH2 inhibitor, tazemetostat, that's been approved for mutation positive after 2 lines, and for EZH2 wild type or unknown with no alternatives available. Also, fairly recently, anti-CD19 CAR T-cell has been approved for patients who have failed 2 or more systemic therapies, and this is also relatively new. This slide shows the ESMO guidelines, which are also supported by EHA and endorsed. And they do it a little bit differently. They break it out into low tumor burden or high tumor burden, and then, of course, first-line or relapse disease. And you can see that for the patients with low tumor burden, if they have low grade disease, low volume disease, then you may certainly do watch and wait, as we do in our guidelines. And there are other therapies that are options here that are listed. For patients with high tumor burden and advanced stage disease, they separate it by age, and you can see the number of different options there that are listed, including many of the options we just talked about in the NCCN guidelines. Current treatment guidelines for marginal zone lymphoma for NCCN guidelines are listed here for second line or later. You can see, again, many of the same treatments that we just talked about for follicular lymphoma. And one addition is ibrutinib, does have some excellent activity for marginal zone lymphoma. And other recommended regimens you can see listed there as well, very similar to what we talked about for follicular lymphoma. The ESMO guidelines and EHA endorsed guidelines, they also do this a little bit differently. Asymptomatic patients would be observed, as we often do. For patients with localized disease, radiation therapy would certainly be an option, is something that we also recommend as well. If systemic therapy is needed, certainly chemoimmunotherapy can be given and repeated if there's a long initial remission, 24 months or more. If the patient relapses in a short time, probably that's not a good option. They also discuss autologous transplant considered for patients that have more clinically aggressive disease, and talk about ibrutinib, again, a single agent for relapse refractory marginal zone lymphoma. PI3 kinase inhibitors, including copanlisib, have demonstrated efficacy and have a manageable safety profile for pretreated patients with marginal zone lymphoma. Certainly, patients can be entered in clinical trials at any point in time. The rationale for PI3 kinase inhibitors are shown on this slide, and they're classified in their roles of proliferation, growth, and survival of the B cells. And proteins are classified according to their structure. There's 3 classes, and the class 1 family is most closely associated with human cancer. The roles in the B cells, malignancies, are listed here, and you can see there's different isoforms, and they have different roles in normal human lymphocytes versus the role in B cell malignancies. And all of the different subtypes have been potentially targeted with some of our agents. This slide just demonstrates some of the different pathways that the PI3 kinase inhibit. You can see it can be actually at multiple different areas and can depend on the subtype of PI3 kinase where it's going to target in the B lymphocyte. The mechanism of action of the isoform can have, again, different targets. So the PI3 kinase isoforms a pan-PI3 kinase inhibitor called copanlisib, which is a class 1 inhibitor, actually targets all the different isoforms. Idelalisib, umbralisib target the delta isoform, and duvelisib targets both the delta and gamma isoforms. So these may have different activities and may also be associated with different toxicities that we'll talk about today. I'd like to thank you for listening today to our segment and listening to our 2 speakers coming up very soon. Thank you.